in terms of pathology, let's talk about the meaning of demyelinating diseases. Studies have shown that demyelinating diseases are acquired diseases, acquired conditions, and they lead to damage to the myelin, but they preserve the axons. After time, they will lead to also damage to the axons, like we talked about peripheral neuropathy. So the natural course of this demyelinating disease is determined by two situations: the capacity of the CNS to regenerate and the degree of the secondary damage to the axons, how much the axons have been affected. So what are the common or the most important list of demyelinating diseases that you as a medical student should know something about? Of course, the list is huge, but the most important one will be listed here. And the most important one is multiple sclerosis. Then you have another called multiple sclerosis variant. So it doesn't have the full-blown picture of multiple sclerosis, but it's in between or borderline. So it's another topic. And then you have something called acute disseminated encephalomyelitis. This is a dangerous disease. And then you have another one called acute necrotizing hemorrhagic encephalomyelitis. This is more common in kids. And there is so many other demyelinating diseases. So we are going to focus on the MS as our prototype. And I want you to remember that demyelination is a non-specific reaction. So to many types of CNS injury. So it's not one disease. It's a reaction to CNS injury. And demyelination also can cause edema of the brain. Let's talk about multiple sclerosis. Multiple sclerosis is studied by many research groups, and studies have shown that this is an autoimmune disease. It affects the CNS, and the studies have shown that the trigger is not clear. We don't know what's the trigger, but many research have found virus, DNA material, environmental contribution, and also genetic factors in patient with multiple sclerosis. So like it runs in the family. So antibody titer to many viruses are elevated in multiple sclerosis patients, like varicella zoster, like rubella, like Epstein virus, like herpes virus type 6 has been seen. Antibodies to these viruses are detected. So that's hence the theory that multiple sclerosis is a reaction to a viral infection, a previous viral infection. The pathophysiology, what happens when we have multiple sclerosis. These are the end organ that are affected in multiple sclerosis: the axons, the myelin sheath, the oligodendrocytes, blood vessels, and also cytokines and T cells and antigen-presenting cells have a major role in multiple sclerosis. So during the immune response, the cell, when a patient have an immune response, again, the triggers are many: environmental, genetic, infection, and so many things. So then the antigen-presenting cell will identify an antigen and present it to the antigen-presenting cell, would identify the antigen as of the myelin sheath as foreign antigen. So it will cross-react with the foreign antigen and label the myelin sheath protein as foreign antigen. So this antigen-presenting cell will present the myelin antigen to the T cells as foreign. These T cells have the power to invade the blood-brain barrier. And we know from our study that the blood-brain barrier is an important membrane. It prevents the passage of potential harmful substances through the blood walls into the brain. So the brain is a precious organ, protected very and sealed. So in multiple sclerosis, the blood-brain barrier is leaky. It has a leak, and it allows the activated T cell to cross the blood-brain barrier and to attack the myelin sheath. What happens when it crosses the blood-brain barrier? It will lead to demyelination. And how do we see demyelination in the central nervous system? We will see it as swelling, area of swelling or edema. We will see as aggregation of macrophages, and we will see aggregation of other inflammatory cells, of course, due to activation of cytokines. We will not see cytokines. So blood-brain barrier prevent passage of harmful substances. We know that, and we know that. This is the same repetition of what I talked about, just for you to help you reinforce the pathogenesis of multiple sclerosis. Again, the T cell will pass, and this is just a repetition. Again, this is another picture which can visualize the process of and simplify the process of multiple sclerosis. Of course, the topic is much more deep and much more complicated, but for your level, that's the level that's a concept that we want you to acquire to as a foundation and base for additional information later as you progress in your education. But this is an important foundation for you to understand. If you look at the brain that is affected by multiple sclerosis, we call it multiple sclerotic plaque. What do we see? So because of the activation of the cytokines by the T lymphocytes, you will have inflammatory cascades really leading to aggregation of macrophages and inflammatory cells around blood vessels and around oligodendrocyte myelin unit. So we will call it oligodendrocyte myelin unit. It's just a term. Also, the radiologist and the pathologist agreed to call lesions of multiple sclerosis as plaques. So both will say that there are plaques on the MRI, plaques on histological examination, and plaques are inflamed demyelinated lesions. So there is edema, there is inflammation, and there is damage of the myelin sheath. So demyelination occurs, where does it occur? If we have a patient with the beginning of multiple sclerosis, commonly it starts where? Demyelination commonly starts in the periventricular region. Then it also starts in the optic nerve. These are the favored location for an early multiple sclerosis. Also subpial region and spinal cord. So these are favored location for plaques of multiple sclerosis. I'm going to show you some images of the pathology of multiple sclerosis or the plaques on gross examination and also microscopic examination, which will help you consolidate the theoretical knowledge of pathogenesis. This is a fresh section of the brain, and we can see there is a plaque here, this pink red one, and it's around the ventricle. This is around the occipital horn of the lateral ventricle. This is very interesting, fresh plaque. This is an old section of the bones and of the fourth ventricle. And this is a special stain. This is a histological section. This is not a gross section. Histological section by PAS stain. PAS, periodic acid chaff stain. It will usually stains the lipid and the glycogen in the myelin sheath. And here you can see blue area all around it and pale plaques. These are amyelinated sheets that don't have areas that have no myelin sheet or a damaged myelination. So these are around the ventricles, the fourth ventricle. So we said around the fourth ventricle, optic nerves, and spinal cord. So the white matter, it's a white matter disease, and the white matter lesions are termed plaques and can be small and can be multiple and only recognized by microscopy. You can see it in radiology, and you will have a huge differential. It can be glioma, it can be abscess, it can be infection, it can be ischemia, it can be clot. But when you take a biopsy, you will see features of demyelination and inflammation. Okay. This is another close-up picture of a brain. This is the gray matter, the white matter, and we know the white matter is the matter that contains the axons and the myelin sheath, and you can see here an area of loss of the myelin sheath. It's pink, it's a plaque, it's periventricular. Okay, so this is beside the ventricle, this is in the optic chiasm and brainstem. So demyelination, if you do think of pathophysiology, we have information transmission via axon is interrupted. When you lose the myelin sheath, so you cannot have ascending and descending information. It's either interrupted completely or slowed down. So it interferes with conduction of nerve impulses from sensory organs to the CNS and from CNS to the motor organs, and may result in permanent loss of the transmission, as we talked about it. Now, the body will try to remyelinate, or when you give immune suppressive therapy and targeted therapy and immune modulator therapy, now there's so much research and so many new therapies developed for this disease. Even there is remyelination, there will be a repair process. So the oligodendrocytes will try to build a myelin sheath. In the beginning, it will be thinner and not as effective myelin sheath in terms of the speed of conduction of electrical impulses. So there is still irreversible loss and nerve damage if the treatment is suboptimal or the inflammatory process is aggressive. These are the key features of multiple sclerosis. It's autoimmune disease affecting the central nervous system. It involves myelin damage and interrupts nerve conduction. There is no cure so far, but there is comfort and support therapy, and also research have developed targeted therapy to do immune modulation of this autoimmune attack of the myelin sheath. So response to treatment vary, and we can say it's clinically it will present as relapsing and remitting episodes of neurological deficit, and it is separated in time. So for this, we need to rule out other diseases before we label it as multiple sclerosis. So the white matter lesions are separated in space also, and the prevalence of this disease is 1 in 1,000, so it's not rare. It's more common in women than men and more common in adults. So it, again, just to revise, it's an autoimmune disease caused by combination of environmental and genetic factors which result in loss of tolerance to self-proteins, very important. Now we will cover this in the neurology lectures or with the clinician. Symptoms, so unpredictable, fatigue, depression, weakness, muscle weakness, numbness, blurring of vision, cerebral intentional tremor, seizures, and urine frequency or constipation, all of these, and short-term memory dysfunction. If you do an MRI, what will you see? So investigation, you will see the visual evoked potential also for the is reduced. CSF count you will see protein, elevated protein, and you will see oligoclonal antibodies. So there is elevation of these antibodies that attacks the myelin sheath. MRI, you will see of the spinal cord and CNS to exclude other causes of neurological deficit. It might show you the plaques, but it is important to rule out all these other causes like infection, abscess, neoplasia, metastasis, ischemia, all of that. So then you will need to do other tests like a chest X-ray to rule out primary tumor or neuroendocrine tumor, serum B12, anti-nuclear antibody, and antiphospholipid antibody, serum angiotensin, converting enzyme. These are general tests that should be done. So we need to manage multiple sclerosis. We usually manage the acute episode, so to save the life of the patient, and we need to prevent future relapse, and also we look for complication to prevent side effect, and try to give support to help patient in the disability that she or he developed. Okay. So the pathogenesis, based on the growing understanding of the pathogenesis of MS, therapies are being developed which will modulate and inhibit the T cell response and block the recruitment of T cells. So as I told you that. Prognosis, okay, people have life expectancy 35 years after the onset, but after 25 years, they 2 to 2/3 remain mobile, and later on there will be physical limitation of 70% of the patients, so they need life support. So this is a simple pathogenesis of a good example of demyelinating disease. And now we can go to other acquired demyelinating disease, another, again, basic foundation. So we have acute disseminated encephalomyelitis. This usually occurs post-viral infection, and it also can be autoimmune. Acute necrotizing hemorrhagic encephalomyelitis. It is a life-threatening disease and usually occurs in children. Central pontine myelinolysis. It's a condition usually seen in intensive care patient or emergency department due to rapid correction of hyponatremia. Progressive multifocal leukoencephalopathy, which is caused by Creutzfeldt-Jakob virus, so, or an agent. This is another big topic. So, but all of these, they share the feature of demyelination. Now we want to go and talk about nutritional diseases and effect on the brain. We're going to talk about the value of thymine. Thymine is an important vitamin. It is required for cells to metabolize glucose aerobically and generate ATP. We know that neuronal cells, they depend on glucose and aerobic energy. They depend on glucose. When we have impaired glucose oxidation, the alternative energy fuel for the mitochondria to generate ATP will be to produce pyruvic and lactic acid, which is an anaerobic way. This will lead to vasodilation of the blood vessels and also will lead to increased cardiac output. So thymine is an important component for healthy brain. People who have thymine deficiency develop different type of diseases. Develop Beriberi disease, and Beriberi disease have two categories. It has the dry and the wet. The dry Beriberi usually is presented with a neurological deficit in the form of wrist and foot drop. So again, something with the myelination. But the wet Beriberi, it has more of cardiac and generalized edema and heart failure and pulmonary edema. So this is a very complicated internal medicine subject, but it's important for you to have some foundation in the pathogenesis of these diseases. Then also thymine deficiency will lead to something called Korsakoff syndrome. Korsakoff syndrome will lead to cystic spaces with hemosiderin pigment in the brain. These lesions are in the medial dorsal nucleus and in the thalamus. So this is also a dangerous presentation. Also, thymine deficiency will lead to something called Wernicke encephalopathy. So hemorrhage and necrosis in the mammary bodies and adjacent to the third and fourth ventricle. So thymine deficiency is a very important in the neurological manifestation or diseases because of the role it plays and the type of disease. These diseases are favored in the international board exams because they will differentiate between people who have excess knowledge, good to know, and must know knowledge. However, I would like you to focus. What do you mean, move the window away from? Okay. So now we go to Guillain-Barré syndrome. So before that, okay, we finished this. Now we go to another disease called Guillain-Barré syndrome. Again, it's an important disease. You will hear about it. This is a life-threatening disease. We talked about it before in the beginning, in the first lecture with Dr. Abdurrahman. I think there was a mention about the Guillain-Barré disease. So it's a life-threatening disease, and it's usually follows systemic infection. It is rapidly progressive and ascending. It's characterized by ascending motor weakness. What happened to these patients? They have segmental demyelination. Okay, so they cannot they have segmental loss of the myelin sheath, so the conduction velocity is interrupted, and it can affect vital organ like the diaphragm and the respiratory muscles. What do you do to these patients? How you treat them? Because it's an emergency. You give them plasmapheresis to wash out these autoantibodies that are attacking the myelin sheath, to give them intravenous immunoglobulin, and to give them supportive care if they need ventilation. So in all, this is all with regard to demyelinating diseases of the central and peripheral nervous system. Any question? Are you all here?
Yes, doctor.
Everything is fine? Do you need do you have any question? Okay, so best of luck, and thank you very much, huh?
Doctor,
Yes?
what do we mean by plasmapheresis?
Plasmapheresis is
Yes.
you take the blood and you remove the, you take the plasma of the blood from the blood, and you remove the autoantibodies from the plasma, and then you return the plasma to the patient, because plasma is the liquid that contains immunoglobulin.
And then you later on add intravenous antibodies, right?
Sorry?
And then later on you add the antibodies, the intravenous antibodies, immunoglobulins.
Yeah, but that's the management plan, and it's not your scope. But just understand that the pathogenesis management goes with the clinician, not my topic. But it's you need to remove these autoantibodies, usually through immunopheresis. But this is a big, another highly specialized topic, not your level. But that's what they do. They remove the autoantibody.
Thank you, doctor.
You're welcome. Any other question? Okay, this is an interesting lecture, and it's straightforward and simple, only filled with some names. Try to remember the names and memorize it. It will be good for you. Okay, best of luck. Thank you.
Doctor?
Yeah?
Oh, yes.
Yes.
So what we need to focus on most this session is MS, and the other acquired demyelinating diseases. We need to know like the basic features that you mentioned, and that's about it, right?
Yeah.
Okay, thank you.
Thank you.
Doctor?